Well, we're happy to have Adriana here. She was involved with field studies from 2002 to 2005, is that correct? Going to Latin America several times. And after receiving a BS in Anthropology from BYU, went on to receive an MPH, Master's in Public Health, from Boston University. She tells me that, I've seen that she has been working in, Vietnam, Latin America, especially Guatemala, and then in Boston as well, here domestically. So been doing a lot of work all over the place. I won't spoil too much the presentation that she'll give, but she's been working with sexual health among men in Guatemala, and she'll tell you more about that. We are really pleased to have her. One quick note, there will be some question and answer time afterwards. We're recording this lecture, and so I'm sure everyone here will project, their questions just fine, but we will have a microphone because we want to be able to pick up your questions on the video. So please do wait for that microphone to come around as we do question and answer afterwards. Without further ado, Adriana Smith. Adriana, I don't know how to pronounce it.
Thank you for coming. It's a great pleasure to see so many faces that I'm not the only one interested in what I do. So that's exciting. Just a note on Nephi's comment about questions and comments. I really like participatory discussion. So if you have a question in the moment, ask it and I'll repeat it so it gets recorded. Any other comments or whatever sort of discussion you want to contribute, please feel free. And then we can save some time at the end, but I'd rather it be sort of during the presentation. So Nephi briefly told you a little bit about my background. I was an ISP student. I went to Guatemala in the field study in Guatemala in 2002, and absolutely fell in love with the culture and the people. I had a wonderful experience. And then for the following 3 years was the facilitator. So I had the opportunity to go back and continue being involved in the project. And that launched the skills and the things that I learned and practiced in anthropology, and during that Guatemala field study really launched my interest and my career in various other health promotion programs. And that's what I want to talk to you about, is how to utilize skills and tools learned in anthropology and field studies and the programs that the Kennedy Center offers to develop your career and use those skills in further programs. Let's see. I want a little bit about the Guatemala field study. The purpose, it was through the anthropology department, and it's still in existence, right? Kind of. Dr. Hawkins was the director of the Guatemala field study, and the point of the program was it was cultural immersion. It's practicing ethnographic field skills, different methodologies, and immersing yourself enough to really understand the daily lives of the people you're living with. Guatemala is composed majority of indigenous Maya people. We lived in rural villages, people that spoke Quiche, Maya Quiche, and often this meant traveling long distance in the back of a pickup to get to the small towns, learning to eat corn and rice and beans every day, and helping wash clothes in the river or in the wash basins, going out to the fields and helping men chop and harvest corn, and it's a really different lifestyle. And on top of experiencing and practicing participant observation, but using anthropological qualitative methods, which was interviewing skills and conducting focus groups, working with a translator, doing lots of participant observation activities. So the field study required a prep course initially, 4 months of intensive study on anthropological methods, literature review, and writing a proposal for your research project. Many of you are familiar, I imagine, with this process. How many have participated in a study abroad through the Kennedy Center? How many here? How many, keep your hands up, how many are planning on participating in one in the future? So good, we got a good group here. Nice. So it's an intensive preparation process. 4 months of in-field. The Guatemala field study was 4 months in the field, where you practiced all of these methodologies, lived with people, learned, asked lots of questions, and really discovered lots of new ideas. And then post-field, which I argue is one of the most difficult, because it really forces you to have to write up and review all of your field notes. With the Guatemala field study, we did several, we presented at several conferences, including the American Anthropological Association, the Latin American Studies Association, Inquiry Conference, which is housed here at BYU. And then publication. Writing and publication is a very strenuous process. But I did this for 4 years. The first year I studied the household production system. The main findings, I found that I studied all the ins and outs, what men and women both contributed to the household production system. And my main conclusion was that the value of work was measured on how it contributes to the household needs rather than the monetary value. So there was this complemental relationship between how women provide and how men provide for the household economic system, which of course changes with the influence of market capitalism and large markets coming in and training people more on the idea that labor is valued more based on how much money it brings into the home. Second year I went down, I studied women's conversion and participation in the evangelical movement. Guatemala, next to Brazil, has the highest evangelical conversion rate in all of Latin America. So you see little evangelical churches popping up all over these small communities. And a large majority of the participants are women. So I sort of really delved into why the church attracted women, why women were involved in the churches, and found that much of the reason was because of an alcohol taboo. Women were seeking refuge from alcoholism in their homes, whether it was abuse by their husbands, because alcohol abuse by their husbands or families. Women's tight social networks in the churches, because they had the opportunity to participate they received positions of authority in the church, and the continual support that they received with small group women's meetings as sort of like a group therapy. And then the last year I was there, it was the 10th anniversary of the field study program. So I did an impact assessment to determine what the impact of having 10 to 15 BYU students in these communities each summer had on the community. And in general, found a very a mutual and engaging sort of relationship, that families loved the opportunity of having housing and taking care of BYU students and other students to learn about the outside world. So it was this mutual understanding that you learn from each other as you live together. And I found a little bit of economic dependency in the sense that the shops, the internet cafe blossomed every summer when the students were there, and the shops that sold, the exported Oreo cookies or whatever, there was, and some of the families that continually housed students, it was one of their main forms of income for the year. So those were the 3 projects I did while I was in Guatemala. Do you guys have questions, comments? Malcolm, do you want to add anything? Malcolm was a facilitator and worked in the Guatemala field study as well. So many of the things I learned is from Malcolm. Go ahead. We worked in 3 small towns. Santa Catarina and Ixtahuacan actually split after Hurricane Mitch, and the government sponsored a new town up further in the highlands. So we worked in those 2 towns and sort of really looked at that divergence of those 2 towns and the cultural differences after the split. And then another town was a little bit more industrial, right on the Pan American. Industrial in the sense that they actually had like a weekly market. And that town was called Nahuala. All of them were in Solola, in the western highlands of Guatemala. So after I graduated at BYU, I was really interested in public health. And I think this story just pops out into my mind as something that particularly pushed me into public health. I was living with a family with 6 adorable girls, and they really started to feel like family to me. If you eat and you literally bathe and sleep with these people so closely in such an intimate way, they become family to you. They become much less as scientific observational instruments. I'm not just watching and seeing and understanding, but I'm really building a relationship with these people. One day, one of the girls came up to me and she was complaining of a sore mouth, and she was crying and she was frustrated and angry, and so I had her open up her mouth and I looked inside, and one of her back molars was completely decayed. It was just a giant decayed hole in her mouth. And that, I think, really pushed me to realize that I'd like to go into public health. I'd like to give back. I'd like to do something for the people that I have learned to love and live with for so long. So it was actually that girl right there in the left corner. That was the family I lived with. Let's see, this is a picture of Dr. Hawkins. We met as weekly classes with all of the field study students. This is a market in Guatemala, and there's me and some other girls that I lived with. So after I graduated, there's my project conclusions. At BYU, Dr. Hawkins actually put me in touch with Dr. Kirk Dearden. Does anyone know him here? He used to actually be a professor here in the health science department. And he was looking for a research assistant to do work in Bolivia. And so I signed up immediately. I was born in Bolivia. My family lived there for a couple of years. So I was anxious to get involved in public health in Latin America, and then also go back and visit the place of my birth. So in the Bolivia project, we did a health-seeking behavior study. Acute respiratory infections or severe pneumonia, which is a type of acute respiratory infection, is the #1 killer of children under 5. It represents 20% of all deaths of children under 5. And in Bolivia, it was, I think, 11% of Bolivian children have an ARI, only half of which seek a qualified health provider. So the mortality rate for ARIs is extremely high in Bolivia. So we went down to look at we used a framework called the Pathway to Survival, and I'll get back to that, to really understand how it was that caretakers navigated the interface between household recognition of symptoms and treatment to reaching the health facility. What are all the barriers and what are all the delays in navigating that interface from household to facility? So it was looking at we'll go through it. So the pathway to survival begins with illness onset. If you're navigating in a healthy way, you recognize the problem initially. You decide to seek care. You seek timely care because severe pneumonia can kill an infant within 2 to 3 days. And then you get quality care, which equals survival. If you delay on any of these steps, if you delay in recognizing the problem, deciding to seek care, seeking the timely care, or when you don't get quality care, then it leads to death. So this was the framework we used in the project. Mostly I did focus group discussions with women in the Altiplano of El Alto, which is a town that sits on the outskirts of La Paz, the capital of Bolivia. And we worked also did interviews with a variety of healthcare providers, so natural healers as well as pharmacists, doctors and nurses that worked in health centers. And then we did interviews with women who brought their children into the health centers to determine how they were able to reach to this point and whether they were able to recognize and seek prompt care. I'll go back to these pictures. This was a focus group with a couple of women. I did focus groups with a series of focus groups, so women in co-ops or who are involved in organizations that met weekly, so I could do follow-up focus group discussions with them. This is a large parade they put on annually for the Independence Day, and all year round, people save up money and build these really extravagant costumes. And so the parades in Bolivia are phenomenal. Has anyone been to Bolivia or Andean South America? Yeah, so you know. And then this is actually La Paz. It's very, very high altitude, right in the Andean mountains. And then El Alto was even higher, up on the cliffs of La Paz. Very, very cold climate. And here is me with this is my translator. She spoke Aymara. So she was the one that conducted many of the interviews with traditional healers in Aymara. So I'm just going to do a brief kind of overview of the projects I've been involved in, and then I want to talk about the concepts in anthropology that I've applied to these projects. So I received an MPH in Boston and got involved with Partners in Health in Prevention and Housing Research Center. It's a CDC-funded project, and we worked with the Boston Housing Authority in public housing developments, with residents of housing developments to improve chronic disease. We did chronic disease prevention. So we worked with a mobile health unit. There's a giant van here, which did cholesterol, diabetes risk, high blood pressure, and dental disease screening, and worked with residents of the housing developments that we trained them as community health workers so that they could promote healthy lifestyles in their communities and then also promote people to come out to the mobile health unit when it was parked in the development. So these two ladies are resident health advocates, we called them, community health workers that talked and promoted flyering and informal discussions on a variety of health topics. But they also promoted the health van. A funny story is in these housing developments, there was another similar van, a little bit smaller but still large and white, that was the fried ice cream truck. And so sometimes people would get us confused with the fried ice cream truck. And so we had like little kids like come up and be like, "Mom, I want strawberry," or whatever. And so a couple of times we'd actually park next to the fried ice cream truck so they'd get their cholesterol checked and go down and get the ice cream right afterwards. So anyways, the high rates of cholesterol and diabetes risk were really alarming. And I have some stats here. So overall, this was essentially an evaluation of housing developments where there were resident health advocates and housing developments there weren't, and determined the difference in the people that came out to the van. It was sort of an evaluation piece to the program. So that's why I have intervention control. But total, we had 16% hypertensive. 24% of the people screened had high cholesterol. 63 had a high diabetes risk. 45 needed emergent or urgent dental care, defined as in they had cavities or decaying teeth. So it was really alarming, the need that was there in terms of chronic disease. Any questions about that project? Yeah.
After you determined the need, did you have a thing to help them get there?
Absolutely, yeah. So there was another component of navigating the healthcare system. And we all are familiar with the very complicated U.S. healthcare system and the urgent need for reform, which we're going through right now. And I found the healthcare system very difficult. Just to get an appointment for someone who's underinsured or uninsured or undocumented is very difficult. So many of our health resident health advocates knew the system because they grew up in the system. They had kids and they know how to get an appointment. So they help people after they were screened with a positive screening. They sat down. I don't know if you guys saw that little referral table right here. They came down outside of the van and they sat down here and they called up the health centers immediately and made appointments for them. And then if they felt uncomfortable going to the appointments, either for language issues or documentation issues, they walked with them to the health center. And then Massachusetts, while I was working on this project, passed the universal health insurance law. So we were signing people up for health insurance also at that time. Any other questions? But yeah.
Was there any follow-up?
Yes, that was another evaluation piece. We wanted to, so we called health. We had them sign consent forms to ask if we could call the health centers to see if they were able to make their appointments. And disappointingly, the number of the percentage of people that actually made their appointments was quite low. So that was a finding that we used to improve that aspect in the next year around. But it was quite low because of a lot of barriers people face. And even when I have to make a dentist appointment, it's such a pain. Just who does my insurance carry, and where's the closest dental center, and who's going to watch my kids, and all kinds of issues people face, so they don't get proper care. Other questions? So while I was working with a professor at Boston University who was involved in a project through the Hanoi School of Public Health in Vietnam. And she got me involved. I didn't travel to Vietnam, but I was involved in this project just on the qualitative analysis component. Because of the experience I had in Guatemala and doing qualitative data collection and analysis, she was interested in my help in this project. So this project was a public policy program evaluation. It involved several public sectors in Vietnam, including health sector, the Department of Education, public security, social affairs, planning and finance, culture and information, justice. Many public sectors were involved. A very large project to train public sectors on how to implement more effective HIV/AIDS programs, implement programs, and in a more holistic approach. So what this involved was semi-structured interviews with 229 cadre members. Cadre members were the leaders in each of these public sectors. 159 staff members, which were working members of each of these public sectors. 111 key informant interviews with peer educators and peer educators of people living with HIV, peer educators of injection drug users, and commercial sex workers. 14 NGO leaders, 17 focus groups, which is a total of 530 documents to analyze. And if anyone's worked with qualitative data, this is a monster. It was a beast because each interview is 10 to 15 pages long, and qualitative data is thick. You have to find and pull out meaning. It's not just punching into an Excel worksheet, yes, no. So this required a whole team of us analyzing this data, and we used a software program called NVivo. There's several qualitative analysis software programs. And I had taken a course on NVivo, and so she brought me into the team as the NVivo expert. And so I was able to train the team on how to use NVivo and tackle over 500 interviews, which was all qualitative, a real challenge. So basically, the intervention was using this comprehensive response for HIV/AIDS programming, looking not only at treatment and care, but the impact. Start with prevention of infection. So prevention of HIV transmission and infection, how it's treated and cared for, and then the impact mitigation, which is the social response. How's it impacting the society and culture, and addressing those issues. So it's not just an issue for the health department. It's an issue for the justice department. It's an issue for the culture and information department. It's an issue for the education department, all working collaboratively to attack and lessen HIV transmission. And then we used these 4 different lenses to look and evaluate the difference between pre and post intervention. We through human rights, gender equity, GIPA, which stands for Greater Involvement of People Living with AIDS, and a multi-sectoral approach. How each of these public sectors viewed these 4 things before and after this large training. Questions about that? Okay. And now I'm currently working in Guatemala, and this actually just fell serendipitously together. I was in Boston looking for work, looking to want to go back to Guatemala, really interested in reproductive health, and met the woman who founded the organization when she came to Boston to give a talk on the organization. And when a position applied, it was when I was looking for something new, and applied and was on a plane within 2 weeks. So now I've been working with WINGS, stands for Women's International Network for Guatemalan Solutions. It's an NGO that works in reproductive health. It's a small NGO. We have a staff of 25 members. There are probably 5 or 6 foreign expats there, and the rest of the staff are Guatemalans. So we work on a number of reproductive health issues. We work in detection and prevention detection of cervical cancer. We promote and educate families on family planning methods, on the prevention of STIs, and implementing sexual curriculum in the school programs in the schools. So the program that I coordinate is Wings for Men, and this program was initiated when Wings did a barrier analysis several years back as to the major reasons why women weren't using family planning methods. And of course, the obvious barriers, they didn't have information about them. The clinic was too far away, costs, kinds of things. But a large barrier was a partner barrier, that their partners refused to allow them to use family planning methods, or just absolutely refused that that they could use them. So in response to that, we implemented the Wings for Men program, where we educate men on family planning methods, but we also, it's more holistic in that we talk about their own sexual and reproductive health. So we do this with 4 different components. We run workshops, small group workshops for men, and it's not me doing the workshops. I supervise an educator who runs small group workshops with 8 to 12 men, groups of 8 to 12 men, and talk about responsible fatherhood and STIs, and family planning, and partner communication, and gender. What does gender mean? And often, and I review the summaries, and I talk to my educator, so I get an idea of what's going on in these meetings. And the couple of them I've been able to attend with groups of men who are particularly open-minded about having a foreign female join them, talking about their body. So I've attended a couple of these meetings, and they're really powerful sessions in the sense that it gives men an opportunity for the first time in their lives. They have a forum to talk about these things and get accurate information. Our module on responsible fatherhood, we have men talk about the relationship that they have with their fathers. And often these men, for the first time, are talking about abuse, or talking about what kind of father they don't want to be, or what kind of father they do want to be for their kids. And it's a really exciting thing for these men. We also have a media campaign in which we distribute through print materials, radio spots, and CDs with our radio spots. We've also done a couple TV appearances about the importance of involving men in sexual and reproductive health. And I put a couple of examples in the back table if you're interested in they're all in Spanish if you're interested in looking at those. But we use print materials that the educators and our peer educators distribute in all of these communities. We recently underwent an evaluation, which we conducted 400 surveys asking random men in these communities if they've seen or heard any of our materials, and 63% of the men we interviewed had seen the materials, which is really successful for a media campaign. And then we also have a peer education component. Men who've attended the workshops or who are natural leaders in the communities are trained to be other educators in the communities themselves. One thing we found is that men don't often go to health centers. Health centers are sort of stigmatized as just for women and children. And they're often embarrassed to go to pharmacies to ask for condoms, or if they have an STI infection. And so they suffer a lot. There's not a health source for them where they can feel comfortable. So we train peer educators in those communities where men can go to the peer educators and ask those personal questions. And then we also do a training for healthcare providers. Like I mentioned, men don't go to the health centers, and for a number of reasons. It's not an environment that's conducive and male-friendly. There's pictures of women and children all over the place, and the family planning clinics are often called Clínica de la Mujer, the women's clinic. A man wouldn't feel comfortable walking into a clinic. So we train health providers about how to offer better services to men, how to make them feel more comfortable, and how to do outreach in the community so they do seek services from the health centers. So that's a project that I'm currently working on. Do I have questions? Yeah.
What changes have you seen come about through this intervention?
Yeah. So each component we monitor and evaluate. And the largest change, the most obvious change, is just basic knowledge. Knowledge of STIs, of condom use, of vasectomy, what a vasectomy is, of anatomy. And so we do pre- and post-tests in the workshops. And the difference between a man knowing what a vasectomy is or how it works from pre-workshop to the last workshop, it's a series of 6 workshops, is vastly different. Attitudes also change, attitudes towards family planning, attitudes towards who should be responsible for choosing a method and using the method changes. And then behavior differences are more difficult to capture because they're often over a longer period of time. But we try to capture behavior differences by doing focus group discussions with men 3 months after they've attended the workshops. And we do see behavior differences, that they're talking to their partners now about family planning, or they're using a condom, or they're going to the health centers to get tested for HIV or other STIs. Yeah?
How do you choose the men for the workshops, and how do you if they're not working with a health center, how do you get them to come in?
Yeah, mostly it's in when the educator distributes media materials. He's walking into brothels, into bars, into police stations, posting these posters, distributing the materials, and talking to men about the information, saying, we offer these workshops. And they're, well, that sounds kind of cool. You know, and they self-organize. And so the educator comes to the place where they want to meet, and with all of the materials. And so they are in charge of organizing and setting up the place. And quite honestly, we've had waiting lists of men who are interested in workshops. It's not offered. It's something completely new. So men are very interested. Yeah. So these are kind of the concepts, basic anthropological concepts I want to talk about, and how I've used these concepts in these 4 projects. Starting with ethnocentrism and cultural relativity. So can someone give me a definition of ethnocentrism? I know there's some anthropologists in here. Yeah.
Basically, the approach that the society and the culture that you come from is superior, or that one culture is superior to others.
Yeah, you're judging or viewing other cultures based on your own cultural values, right? So what's cultural relativity? Any ideas? Yeah.
Is it like comparing your culture and other cultures between each other based on values? Is it like the value of that culture as opposed to whether or not it's different?
Yeah, that's right. It's the opposite of being ethnocentric. It's really understanding the values and the reasons and the meanings behind those behaviors. It's taking away your own biases and really understanding why it is someone does something. I put a picture of a polygamous family up here. I thought that was appropriate for the audience. We can look at polygamy and we can understand. We understand why early Mormons practiced polygamy. It helps a population grow really fast. There were few males and many females. So it's an economic decision. It was a religious decision. So we understand. We understand within the cultural context what's going on. What are the meanings behind the practice? But then you see today polygamist families who are marrying very young girls off against their will, and you're reading about these things kind of in the press, and it looks like a really negative, terrible practice. So my next question then would be, what is the difference between cultural relativism and moral relativism? How do we reconcile those? What is the difference between the two? Because often cultural relativity gets criticized, because if you look at every practice as how it is meaningful and purposeful for society, we then see really negative practices happening. Are we supposed to just understand them within the context and overlook the negativity? What is the difference between moral and cultural relativity? Ideas? Yeah.
Well, I think sometimes they overlap, but the important difference to make is that they don't always overlap. And so I spent, my mission in France and Switzerland, and they do things differently there. And it's important to not treat everything that's culturally different as morally wrong. Maybe I'm just repeating what you're saying, but it's to recognize when something to differentiate between the two, we don't have to ignore our moral principles, but we have to recognize when those reach their limit, and when we can recognize a cultural practice as still being valuable.
Yeah, I think the key is really understanding the difference between moral and cultural relativity, in the sense that moral relativity assumes there is no truth, that anything goes. Cultural relativity is just really looking at understanding why something is practiced. People often use the example of female genital cutting, which you've heard of. It's a practice used often in sub-Saharan Africa in which female genitals are either removed or cut. And it's a gruesome practice. Women suffer a lot after undergoing female genital cutting. Yet, if you were in a cultural relativistic approach, you would look at it and you would understand why it's being done. Why is it being practiced? It's a rite of passage. Women go from childhood to womanhood when they go through this process. So why is it being done? But I can still judge it morally. I think it's a terrible, unhealthy practice. But using a cultural relativistic approach, I can understand why. What is the meaning and what is the importance of this? And then to throw in development, how do we encourage change? An appropriate development response is by understanding the meanings behind it. Well, and to encourage change with female genital cutting is understanding, first of all, why are they practicing it? It's a rite of passage. What other rites of passages can we encourage? And several successful projects have been like bloodletting kinds of things, where women do go through a bleeding, but their clitoris isn't cut off. So that's an example of one approach. So I put a picture of a woman sunbathing. Does everyone get that difference between cultural and moral relativity? Is that clear? You can make moral judgments when you're looking at cultural relativity. I have a quote here. Cultural relativity, to phrase it in its starkest abstraction, states the relativity of the part to the whole. The part gains its cultural significance by its place in the whole, cannot retain its integrity in a different situation. So you understand that part by looking at the whole. You can still make a judgment and say that's a negative or a not healthy practice, but I understand the meaning behind it. So I put a picture of a woman sunbathing, which is a negative cultural practice that we participate in. It causes skin cancer. It's terrible for your skin. So what is the cultural relativistic approach? Why do we sunbathe? Why? Yeah.
Because in our society, it's attractive to
Yeah.
have darker skin.
That's right.
Tan lines.
Yeah, it represents health and beauty. You're healthy if you've got this nice suntanned look, right? So what would be the appropriate development response with that approach to promoting healthy behavior change?
Education about skin cancer?
Sure, yes.
Self-tan.
Self-tanners, yeah, or spray-on tans still fulfill the need of that beauty and that dark skin look, but don't get skin cancer. But yeah, some education about skin cancer that's more what I was looking at. So that's kind of how I sort of broaching that question of how we reconcile relativism and development. When relativism implies understanding and really getting at the meanings behind things, and development implies change. So how do we reconcile those two together? Yeah.
I was just wondering, well, what do you do in a situation where there doesn't really seem, I guess this is where you'd have to...
Oh, sorry, I'm supposed to be repeating questions. Go ahead.
For instance, I spent my, is it on? I'm sorry.
I think they're picking it up.
Okay, I spent my study abroad in Austria, and it is a very common cultural practice for everyone to smoke. I mean, literally, you're seeing 12-year-olds getting cigarettes out of vending machines. And also something that I found very appalling particularly was pregnant women smoking. And I just couldn't understand how they could make that decision. But it's more of a social thing to them more than a health decision. But with those women, I mean, you can't really say, oh, still just take the nicotine patch. It's still negative for the child. So what would you do in that? What would you suggest?
Right. Well, you're getting at what's the social significance of smoking? It's very social. Have you guys seen the healthy cigarette ads? It's something new. There's a healthy cigarette that's coming out. It's supposed to have much less nicotine and that sort of thing. So people are approaching it in various ways. So offering that social environment, but in a more healthy practice. No, yeah. Let's move on. Okay, so another concept in anthropology, we often talk about the emic and the etic. Can someone tell me the difference between the two? Yeah.
I might be getting them backwards. But is an emic looking from an insider's perspective, and etic is taking an outsider's perspective?
Yeah, that's right. That's the difference. So the key to emic and etic is the advantages of both, and how both of them, used together, really describe the full picture. Different perspectives provide the more complete picture. For example, foreign Caucasian female working in Guatemalan male sexual health. I think you can't get more etic than that. But I do represent, I have a different perspective on the issue, and I am able to add a more complete picture. My educator is a Guatemalan man, and the two of us, when we get together, when we brainstorm, we bring completely new ideas to the table. Let's see. What do I have? Outsider. I don't have it up here, but I also have an advantage as an outsider. And I'll give you an example. I was working, doing this evaluation of the media campaign, and really just talking to men working in their fields, on the street, in their shops, about STIs, condom use, vasectomies, sexual activity with their partners. And surprisingly enough, men were open to me. They were answering these questions, and they were asking questions, and they were not ashamed. And I give part of that reasoning to the fact that I am a foreign person coming into the town, and they know that I'm not going to share this information with their friends and family and people that they know, that I represent an outside, so that I am a comfortable venue to talk to about these things. So that's an example. A key part of being coming from an ethic perspective is participant observation. The importance of really just observing and understanding what's going on around you. Let's see what I have here. And the example would be living and doing this field study in Guatemala. A large part of what we did was just living, just sitting in the kitchen and chatting and helping the women make tortillas and just observing. And if you're coming from an etic perspective, this is essential in order to fully understand what's going on around you. Another key piece to coming from an etic perspective is taking the approach that the people that you're talking to are the experts. You're not the expert. You're learning from them. And this is what I did with the focus group discussions in Bolivia with women. When we're talking about healthcare seeking practices with their children, I tell them initially, I don't have children. I don't live in Bolivia. I don't know what you guys do. You are the experts. So you tell me. And it really invites them and it makes them feel really good. I have something to teach you. And then being an advocate and a mouthpiece. Let's see, an example here. Often the time, let's see. Oh, right. So I did, I was doing a needs assessment in Boston public housing developments. And again, coming from a very etic, I'm like with my plaid shirts and my baseball cap, like knocking doors and talking to people about what are the kinds of things, because this is when we were reevaluating the project and deciding what's the most appropriate implementation, the response to needs in these housing developments. And I knocked on a door, and most of the day people were pretty friendly. But this guy came to the door, and I was like, what are some of the things that, this is the organization I work for, this is the project we do, how do you feel about the project, how could we improve the project, what are some other things that we could be doing? And he really railed on me. He got very, very upset that I was a foreign white female talking to him about his problems. But what do you know about my problems? And he drilled me, and he said, have you ever been addicted to cocaine or crack? Have you ever been an alcoholic? Have you ever, just drilled? And here I was going, no. But as soon as I got the guts up, I responded, But do you know what I am? Do you know what I can do? I can listen. And that's what I'm doing. I'm listening because I can be a mouthpiece. I can be an advocate for you. And I'm in a position of power that I can tell my bosses and my supervisors what you're telling me now, and your voice will be heard. And as soon as I stood up to him, he respected me and immediately thanked me. Immediately thanked me for what I was doing and for the project, and understood that I could serve in that model. I may not be an alcoholic and addicted to crack cocaine, but I can be a mouthpiece and an advocate if I use appropriate methods. So we'll move on to the EMIC perspective. And I know we're running short on time. So let me decide what I want to most focus on here. We've got 10 minutes, so people have to go to classes, huh? Well, EMIC perspective clearly is essential. It's using participants in which the program is implemented for and involving them in the planning and in the design and the carry-out of the program. And so in many of these projects, we rely on community health workers, rely on peer education, mentoring, greater involvement of people living with AIDS, the Vietnam study, and the value of the insider's knowledge, and then also participatory learning. And all of the workshops and all of the trainings that we do with men in Guatemala, they are involved in the learning. They come up with the conclusions. And I wanted to do an activity, but I don't think we have time for that. But it's that people making their own conclusions and coming to the answers because of their participation in the activities. Let's move on here. So benefits of qualitative data collection and analysis, which is a large piece of anthropology. Quantitative definitely has its benefits, but so does qualitative. It explains really more of the why and how rather than the what. And just like in the Vietnam project, I had to rely on, we use qualitative interviews because of the management of those non-concrete topics like gender and self-efficacy. You can't measure those things with quantitative numbers, so you really had to pull those themes out with in-depth qualitative interviews. I've used qualitative data collection skills in monitoring and evaluation of all the programs I've been involved in, because you have to monitor and evaluate to measure whether they're successful programs. In rapid rural appraisals, we did a rapid rural appraisal for the men's program, in which we worked in a couple of communities identifying men's interest, need, and the best way to implement the men's program. And then also that qualitative data collection is iterative process in the sense that you don't begin necessarily with all of your research questions. You, as you go along, as the project develops, you learn the kinds of questions you should be asking. And I'll leave with one example in Bolivia, and I always get emotional, so I'm pre-warning you. When I was working in Bolivia on this acute respiratory infection study, like I explained earlier, I was doing a barrier analysis essentially, what it was, how women navigated that interface between household and clinic, and what was keeping women from seeking appropriate prompt health care. And I was there for 3.5 months, studying and interviewing and identifying all these barriers. And 2 weeks before I left home, I sat down with a community health worker who does at-home visits, and talking to him about all my findings and getting feedback from him. And he said, it looks good. You've missed one major thing. He said, women in these towns don't know anything about family planning, and they don't have access to family planning methods, and they have many more children than they can take care of. And so I visited many homes. When a child gets sick, they leave the child in the corner to die. And it flipped my project on its head, and I realized I had been missing a really large component. I had been working this whole time under the assumption that people seek care when a child is sick. But yet, there's something so much more fundamental, deeper, that I had overlooked. And that's a key component of qualitative data analysis and research, is really identifying what are the questions you should be asking, instead of coming with your own agenda. So I think I will stop there. But if you have further questions, I'd be happy to chat with you afterwards and maybe tell you a little bit more of the presentation I wasn't able to give. But thank you very much. And I encourage you all to be involved in field study programs here. They really do offer you amazing new perspectives on the world and give you really, really good skills for your career toolbox in the future. So thank you very much.